later on. Our second speaker is Dr. Abdelaly Dabosy. Dr. Ali is a consultant pediatrician and chair of Paediatric Division and Sheikh Shakhbout Medical City, Abu Dhabi, United Arab Emirates, a fellow of the Royal College of Pediatrics and Child Health, London, UK. Graduated from Benghazi, Libya, trained in Manchester, UK, and was awarded CCT in pediatrics. He worked as a consultant pediatrician at Royal Manchester Children's Hospital, Manchester, UK, until he joined SAHA in 2013. He's a pediatric examiner, peer reviewer, certified in medical quality by American Board of Medical Quality. Welcome, Dr. Abdelaly, and we will start with his lecture about barking the wrong tree, that less missed. What is it exactly? About rare diseases, challenges, and burden. Please, Dr. Ali, you are welcome. Thank you.
Thank you very much, Dr. Yassin, for the kind introduction. Thank you very much to the conference chairman, Dr. Tariq Al-Azabi, and the co-chairman, Dr. Mahmoud Abeda, and to my colleagues in the organization and the scientific committees. My talk tonight is about barking up the wrong tree, or our tendency to chase false dawns. I have no disclosures to make other than a confession that I am not an expert in rare diseases, but I am a child health and rare diseases advocate. Hopefully at the end of this talk, you will know why I am talking about rare diseases in a conference about neurodisability. I will discuss the burden of rare diseases and the challenges to carers, to patients, and to physicians. And I will, half of the talk will be about our disability as physicians, the cognitive biases that contribute to misdiagnosis in general and misdiagnosis of rare diseases. When I was at medical school, one of my colleagues who was studying economics, he used to tease me with this quote from Voltaire, that doctors are men who prescribe medicines about which they know little, to cure diseases of which they know less, in human beings of whom they know nothing. 30 years, well, more than 3 decades ago, I was extremely defensive of the medical profession. More than 3 decades on, I am not as enthusiastic. I believe that we doctors, we have a case to answer. So why I'm talking about rare diseases in a conference about neurologic conditions and neurodisability? Because if you look at the database of rare diseases, the 8,000 something rare diseases, there is a significant proportion of those rare diseases that actually lead to neurologic conditions and neurodisability. Personally, I prefer to use the term orphan disease rather than rare disease. Being rarity is just a statistic, while being an orphan is a full-blown tragedy. There are several definitions to labeling a rare disease, but probably one of the most commonest is a disease that's affecting 1 or less in 2,000 of the general population. There are over 8,000 rare diseases in the rare disease database as of now, and this database is increasing every month. There are around 300 million people suffering with rare diseases. 50% of those affected are children, so there is that is what our role as pediatricians and those who dealing with children, we have a major role in undigging and coming up and diagnosing those kids with undiagnosed rare conditions. Out of the 8,000 plus rare diseases, only 5% have approved treatments. So that's just over 400. So when it comes why we have difficulties with diagnosis of rare diseases. So we physicians, we often haven't seen or studied much of the rare diseases. So there is a problem of awareness and knowledge. And because we are not aware of the conditions, we tend to dismiss the patient's symptoms. So sufferers with rare conditions often find the validity of their symptoms being questioned by us physicians. And diagnosis typically will take several years. During that time, the patient will be passed from one specialist to another. According to the Australian Rare Disease Survey from 2014, the average time of diagnosis of a rare disease, in 45% of cases, it takes up to 5 years. In another third of cases, it takes anything from 5 to 20 years plus. And during this time, around 35% of patients will be seen by 3 to 5 doctors, and another third will be seen by anything between 6 and more than 10 physicians. So it looks like rare diseases are really orphaned. They virtually ignored with very little, if any, attention from our side as physicians. The typical busy practitioner is expected to see around 1 case a year. And it seems that we have this mindset that it's not cost effective to invest time or money in chasing rare diseases. However, we need to remember that there is no disease is rare if that disease strikes someone we love, someone we care about. When it comes to the issues of those suffering with rare diseases, first thing, it is the illness itself. Then the second hurdle is finding an engaged and knowledgeable physician who have the curiosity, the knowledge, the expertise to explore and investigate. Then the third milestone is arriving at the diagnosis. Then once diagnosed, only 5% of those diagnosed with rare disease have already approved therapies. So finding a therapy itself is less likely to happen than it will happen. Then even those 5% of rare diseases with approved therapies, there are issues with access to healthcare and insurance. When it comes to what patients feel, those who suffer with rare disease, what they feel. One sufferer with rare disease said, "I just want to know what's wrong with me so I can fight it." Another lady who had a rare disease said, "Some days I wish I had a cancer." When you have a disease like mine, she means that's a rare disease, you don't fall through the cracks in the system, you fall through a gaping abyss. So rare disease sufferers, they fell out of the healthcare basket, they are off the radar. Patients reported that they are feeling alone, in a nightmare, virtually or practically abandoned by the medical profession. An eloquent rare disease sufferer put it beautifully, an exercise in patience. When it comes to those who care for patients with rare diseases, what they feel, the carers, so they are scared because of this uncertainty. They feel helpless because there is not much medical care available, or in the minority with available health care, it's not accessible. They feel exhausted. A lady her husband survived heart and lung transplant. Then after that, he was diagnosed with a rare disease. She commented that having dealt with his diagnosis means the heart and lung transplant, and later his undiagnosed health problem, I can say that the latter is so much worse. So in this lady who's her partner suffered a rare disease, the impact of the rare disease on this family was much worse than the impact on someone who had heart and lung transplant. When it comes to us as physicians, what we feel when we come to deal with the rare disease, we are trained to help, and people seek our help as experts in our subjects. However, we are not certain what to do when we don't know. We have a problem in navigating the unknown, the uncertain. We find diagnostic enigma frustrating, time-consuming, and it is indeed humbling. What makes medicine interesting and what also makes medicine frustrating is how much of the clues, of the signs we have, how much of that is signal and how much of that is a noise. So grabbing or getting the signal out of all the noise, the accompanying noise, is a real struggle. As trainees, we all been taught, when you hear hoofbeats, think of horses, not zebras. This quote is attributed to 18th century American physician. At the time, horses was the main mode of transport in cities, and he used this term or this quote or these statements to alert trainees that when they are considering differentials, they need to think of common causes. They need to consider the base rate, the epidemiology, the chance of a disease happening when they are drawing their differential diagnosis. In other words, he's telling them that common things are common. However, the problem, if we never think of zebras, we will never diagnose a rare disease. And the counter quote is that if it looks like a duck, walks like a duck, and quacks like a duck, then it just may be a duck, unless it is a zebra impersonating duck. And indeed, rare diseases can mimic the presentation of more common diseases. So what is the problem? Why we physicians are reluctant to consider rare diseases? Why we are not entertaining zebras? So first, we are brainwashed or indoctrinated to think of common causes, common hypotheses, or the horses rather than the zebras. The other thing, it's lack of knowledge, lack of awareness and confidence to make a rare diagnosis. We don't want to be seen as unrealistic. We are very wary of our image, how others see us, how they perceive us. So we don't want someone to think of us that we are unrealistic and chasing extremely statistically unlikely probability. With limited resources, we are keen at utilizing resources effectively. So the resources is usually directed to common conditions. And unfortunately, the environment we practice in, the busy environment, the overbooked clinics, the hectic emergency rooms, is perceived or is a barrier that prevents us from chasing or considering or pursuing rare pathologies. So the term zebra retreat, it is a term to describe that when we consider a rare disease, we retreat because that disease is unfamiliar, we are unfamiliar with it or extremely rare. I'm sure you all recall this statement that it will resonate in, but it is extremely rare. And I have never seen one. So when we consider rare differentials, we will retreat and retreat from considering zebras and go to the common causes or the horses. A differential diagnosis may include some zebras or rare diseases. And in the zebra retreat is where a rare disease figures in the differential diagnosis list, but we are reluctant to make the diagnosis and we will retreat rather than commit ourselves to a rare cause. This usually leads to delayed diagnosis and, more importantly, missing a diagnosis that may require timely or urgent attention. One of the other factors that playing in our mind is social proof. We have a tendency to stick with the group. For our hunter-gatherer ancestors, sticking with the group was the most successful insurance policy. Those Homo sapiens who didn't stick with the group, they didn't make it and they exited the gene pool. So we are the descendants of those who stick with the group. The other name of social proof or herding or conformity, it is a tendency or a phenomena by which we follow the behavior of the group. And rather than deciding independently on the basis of our own judgment, we have a tendency to conform to the choice of the majority. Peer pressure forces us to retreat from considering rare differentials. One of the other interesting observations about the way we think is the domain dependence of knowledge. And by that, it's the way we think will differ depending on the domain. So if you ask a medical student in a theory exam about a differential diagnosis, they will bring to you the rare differentials. However, when you throw that young physician into the real clinical world, they will completely ignore rare differentials. And this is a contributor to the know-do gap. There is always a lapse between, or a gap between what we know and what we practice or what we preach on a daily basis. Another cognitive error contributing to misdiagnosis is satisficing error. The term is coined by mixing together satisfy and suffice. The other name of this error is premature closure or unpacking. And by that, the meaning of that, when we are considering a diagnostic problem, once we come across something that fits, a hypothesis that seems to be working, we stop all further thinking. The other differentials, the other hypotheses, the other differentials will be left unexplored, unconsidered. It is that eureka moment that stops all further thinking and deliberation. In the emergency room, there is a saying that the most commonly missed fracture is the second fracture, because it's a human tendency. Once we find an abnormality, we cease looking for other abnormalities or other pathology. Another cognitive error that contributes to misdiagnosis is representativeness error or stereotype. The way we make diagnosis, we compare the presenting problem or the presenting condition to the degree of resemblance to a pre-existing typical mental model. So this leads to that this causes that we delete diseases or differentials or hypotheses that doesn't match the typical presentation. This contributes to diagnostic errors in atypical presentations of common diseases, as well as presentations of rare diseases that mimic common disease. Another diagnostic pitfall is diagnosis momentum. And by that, we mean that once a diagnostic label is attached, the more chronic the problem is, the more the patient has seen physicians, this diagnostic label will become only stickier and more stickier. In a busy practice, it's much easier to perpetuate what's the diagnostic label that's been laid before, rather than investing the time and effort to question the accuracy and dig further. And in this particular diagnosis, we need to be wary of the known case. There are many known cases or kids labeled as known cases. They are actually unknown. They are waiting for that curious physician to explore and to uncover the unknown. Another major contributor to diagnostic errors is confirmation bias. Rolf Dobelli, the Swiss author, in his book, The Art of Thinking Clearly, said that confirmation bias is the father and mother of all diagnostic errors. And by confirmation bias, we mean it's our tendency toward only seeking or only seeing information that confirms and conform and support the hypothesis or diagnosis that we are entertaining. This is how our brain is wired. And it also leads to interpreting ambiguous information, ambiguous data in line with our expectation, in line with our working hypothesis. Seeking disconfirming evidence doesn't come naturally. It's a conscious process that, as physicians, we need to develop. Medicine and life in large is very uncertain. And to navigate uncertainty, there's a significant portion of our daily practice of what we do every single day is deeply rooted in dogma, dictum, myths, and tradition. Even several decades after the introduction of the evidence-based medicine paradigm, dogma, dictum, and myths and tradition remain the rule in medicine rather than the exception. I'm sure the term, that is how we have always did it here, will resonate with most of the audience. Medicine is largely uncertain and we need dogma to function. It's easier to perpetuate rather than to deliberate and investigate. Especially in this age, we need to remember that scientific facts has a half-life. What has been certain a few years ago is now a myth. And the other thing, we humans, we are not good at unlearning. We need to unlearn the facts that has been expired to acquire new information. I forget the name of the gentleman who said once that medicine advances one funeral at a time. And by that, he means that the current generation of physicians has to pass away with their misconceptions, traditions, myths, dictums, for a new generation to come to embrace the facts that's been around us right now, but we are not embracing. The British physicist Stephen Hawking once said, "The greatest enemy of knowledge is not ignorance, it's the illusion of knowledge." The illusion of knowledge gives us that relaxation, that certainty, so we don't chase new information. So what could we do? You could name these the simple questions or the stupid questions, but I label them as the beautiful questions. So how can we seek information to falsify hypothesis? How we could seek disconfirming evidence? So whenever we face it with diagnostic problem, we need to ask ourselves what else it could be. So this will expand our differential diagnosis list and hopefully include some of the zebras. Then to disengage ourselves from confirmation bias, we need to consciously look for disconfirming evidence. Does anything not fit in here? Then we need to ask ourselves what I can't afford to miss in this particular child, in this particular presentation. And the way we brainwash it to look for one hypothesis that explains everything wrong with the child. However, statistically, you might have more than one pathology going on at the same time. So we need to ask ourselves, could there be more than one process, more than one pathology going on at the same time? Then we need always to consider rare disease. Could it be a zebra? Could it be a zebra mimicking a common condition? I will finish with this note from our founding father, Hippocrates of Kos. He once said, well, that was almost 2,500 years ago, medicine, the most noble of all arts, falls far behind others, thanks to the ignorance of those who practice it. That's all of us. With this, I will finish my presentation. I can only say that life and medicine are extremely ambiguous and uncertain. I can't stress enough, keep it simple, keep it stupid, and consider zebras. Thank you very much.